You are listening to Concussion 101, a patient's guide to getting ahead again. Episode 14, Who Spiked the Punch? Part 2. Today, your host, Dr. Taher Chugh, Sports MD and Medical Director at the York Region Concussion Clinic, will continue his discussion about dizziness post-concussion and talk about rehabilitation for dizziness, including vestibular therapy. Enjoy.
Welcome to the 14th episode of this podcast series, Concussion 101. My name is Dr. Maude Boulanger. I'm a medical doctor at the York Region Concussion Clinic, and I'm here today with Dr. Taher Chugh to continue our discussion on dizziness and imbalance post-concussion. So in our last episode, we introduced the physiology behind dizziness and balance issues. We discussed BPPV, and we started discussing the treatment of dizziness and imbalance due to sensory organization dysfunction. Now, the type of rehabilitation that is used to treat dizziness and balance issues is often referred to as vestibular therapy. Dr. Chugh, can you tell us a bit about what vestibular rehabilitation is?
Vestibular therapy is prescribed to reduce the experience of dizziness and to improve balance. There are three main rehab strategies that are used to achieve this. One is known as adaptation, meaning that the relevant neural circuitry could recover or just readjust the way it interprets and reacts to the given sensation. So that at the end of the day, the patient feels even or back to the way they were before they had this injury. So for example, we have a doll's eye reflex called the vestibulo-ocular reflex, or VOR. If this becomes sluggish, it can often be trained in a way that it adapts to its new situation to speed back up. Another strategy another one after adaptation is substitution, the ability to substitute another process for an inefficient one. So, for example, if the doll's eye reflex can't adapt entirely, then we can substitute our visual system's ability to accurately jump from one target to another, like we do when we read. And this can kind of replace the smooth doll's eye reflex. And then the third strategy is habituation, or the ability to get used to the symptoms that you find bothersome.
So habituation is where the patient does the same activity repeatedly in gradually increasing doses, kind of like the principle behind allergy shots, so that it no longer bothers them.
Exactly. It's like you don't have to love it, but try not to hate it, and your brain will start to accept it and work with it and normalize it.
And acceptance is a good starting point for any rehab program. Now, the vestibular therapy we give for concussion patients tends to be slightly different than the rehab received by patients who don't have concussions but have vestibular issues.
Yes, so in our experience, vestibular therapy in the post-concussion population is best handled slightly differently. This is basically because for most post-concussion patients, the problem exists in the brain and not the inner ear. So for most vestibular patients, it's an inner ear issue. Obviously, BPPV should be corrected first if it's present, as the brain will get faulty signals from the inner ear until this is corrected, and so won't be able to effectively rebalance the way the senses are weighted. If it's not BPPV, then concussion patients' symptoms are almost always due to issues that originate from the way the signals are handled in the brain, rather than disorders of the inner ear. For example, take chronic subjective dizziness that we discussed earlier. There's a lot of overlap between many different syndromes that can fit with a patient's dizziness or imbalance. But I prefer to describe the components of the patient's dizziness that we identify from their history and from their physical exam. So for example, we want to know if the patient has gait stability deficits.
For our listeners, as the name implies, This means the patient has difficulty moving the eyes as efficiently as they used to. They may lose the ability to stay visually locked on to an object while moving around.
Right. These are not as common in concussion as they are in the inner ear patients. But if identified, adaptation rehab approaches work well as a starting point. More common observations are that the patient has visual motion intolerance, like they have difficulty coping with visually rich areas, like a busy marketplace, or in hallways with many geometric patterns, like a hotel, a museum, casino lobbies, that kind of thing. Mm-hmm. Or they may have motion sensitivity, which means they feel uncomfortable when they move their heads about. Here, reducing the reliance on vision for information about your physical orientation in your surroundings and to uptrain your reliance on your somatosensory and your vestibular system becomes very helpful.
This follows the natural trend of preschoolers to start transitioning away from vision as the principal sense used for postural control, more in favor of the vestibular and somatosensory system, so at around 3.5.
Right. What we see is not under our control. Go to a busy fair or a market, and what you see is unpredictable. And so if you're orienting yourself to what you see, you may be in for a bit of a bumpy experience. But the somatosensory and vestibular systems, they depend on gravity, which is constant and which is reliable. Moreover, the neural wiring from these senses works much faster than the visual system. For example, most of us have seen the trick where someone gives you a coin to put in your hand and you have to keep your hand open. Then the person will challenge you to close your hand as fast as you can once you see him moving in to try to grab the coin. Usually you'll have the coin taken from you because the trickster can move his hand very quickly, whereas there are several milliseconds of delay from the time you first see the motion to the time you relay this information to your brain, and then your brain tells your hand to close. This delay in a post-concussion dizziness context implies decreased efficiency and more potential for maladaptive compensation when you extrapolate this to everyday life tasks.
Can you tell us about postural instability in concussion patients versus inner ear patients?
So there's a lot of overlap. Inner ear patients generally get an inaccurate signal from their vestibular system, and then their brains can compensate for this, sometimes well, and sometimes not with the best strategies. There is some capacity for the inner ears and for the brain to adapt and regain some of what was lost, and that the patient can function well again. And then the patient may need to substitute other strategies like using their somatosensory system more heavily to compensate for the load the vestibular system isn't pulling. Sometimes if there is dizziness and imbalance left over despite using these strategies, then we use habituation strategies.
And many concussion patients also have inner ear issues. So to keep it simple, can you describe the general reason behind postural instability in concussion patients without inner ear issues?
So these patients have normal signals coming from the senses for the most part. Kind of like the mouse to the computer is tracking and clicking correctly, but the way these signals are processed by the computer is not handled like it used to be handled. So these patients may be able to walk just like those without concussions to a casual observer, but they often will use different strategies to do so. Functional imaging of concussion patients show that because of metabolic issues in the involved pathways, the neural pathways, and many pathways in the brain are involved in postural stability, the brain recruits more and more circuits to try to compensate.
So in effect, concussion patients have to work a lot harder to do the same postural task as those without concussions.
Yes, often this compensation is not efficient and so leads to symptoms. An interesting point to mention is that the adult brain weighs about 2 pounds, but uses up about a quarter of all our oxygen and glucose. So inefficiency in the brain can lead to many symptoms, just like when your device's batteries run low, performance quality will drop.
I know we touched on this earlier, but can you discuss briefly how you sort of get the patient to revert back to more efficient ways of postural control?
So our approach is to rebuild the patient's postural control from basics. To sort of recreate the conditions in which they first learned fundamental postural control skills. For some patients, they find it amazing that they can't handle efficiently rolling over like a 4-month-old, and that this rolling provokes symptoms. Like this, we identify the inefficiencies in the patient's strategy, and then get them to work on it in the same sequential order they would have initially developed them in normal human development.
I know a common theme is that patients have a hard time letting go. For example, you discussed in the last episode how coaches often try to get athletes to change their form to unlock more potential, and at first their performance may suffer.
Right. So many patients have duties and responsibilities, so it's only natural that they intuitively find strategies to get around their issues by compensating with other strengths. Like for the athlete, better strategies will allow them to perform better. So to get a patient to stop postural control strategies that they're using with which they are getting by, and even if it's just getting by, and to replace it with one that holds promise of better performance can be hard for them to accept, because when anyone learns a new skill, at first they're likely to have performance compromise. More practically, many don't make the time to give the rehabilitation exercises the time and consistency it needs. Or sometimes anxiety hijacks their brain circuits and makes it hard for them to use those circuits optimally for other things.
Yes, I think we have all experienced that at some point when anxiety doesn't let us perform as well as we would like.
Anxiety in and of itself makes the experience of dizziness much worse. But it also causes someone to sort of desperately search for ways to reduce the dizziness, usually unintentionally, obviously. And that makes the problem so much worse. So for example, we've been treating this young lady for BPPV, who found the symptoms very, very distressing, more so than the average patient. So in reaction to her BPPV and her desperation with it, her brain had tried to adapt to it, and then she regressed to more primitive balance strategies, the kind one would have take two, and regressed to primitive balance strategies, the kind one would have used around 1 to 2 years old. So now she has 2 reasons to feel dizzy.
In a sense, her anxiety made the experience of the dizziness worse, but it also made the dizziness actually worse.
Right. An analogy I give is the one of quicksand. So most don't know, but quicksand is only about 3 feet deep, so nobody should drown in it. But when people panic and move horizontal to try to swim out, that's when they get into trouble.
So here, knowledge is power.
Right. Another analogy would be if you see something squiggly on the ground at night and you think it's a snake, your heart starts racing, your fight or flight system kicks in. But once you shine some light on the situation, you realize it's just a rope, and your frontal lobe of your brain can inhibit the emotional centers of your brain from hijacking the circuitry, and then you calm down.
And this was the case for that young lady.
Right. Just explaining to her the neurophysiology behind her dizziness and how anxiety is basically making her dizziness and her anxiety worse really helped her not fear it so much anymore. Being able to record her nystagmus and show her what was happening validated what she was feeling. And when she got recurrence of her BPPV, she would come in and have it repositioned, and she consciously avoided the trap of falling into primitive balance strategies out of panic or anxiety.
Because now she knew what was going on. That's amazing. Most of us aren't even aware enough to know what the primitive balance strategy is.
Yeah, well, with all our patients, we have to train them to appreciate or become aware of all the senses that go into dictating balance and sense of stability, and tell them to integrate them all in an efficient manner. Most commonly, it's training the patient not to over-rely on their visual system to help with postural control, which is hard for them because adults have a very well-developed visual system. And so the well-intentioned visual system kind of assumes this new role automatically without the patient realizing it, and that's what's setting them back.
Now, speaking of this, you have an interesting story about one of our colleagues and how knowledge and a calm demeanor help him recover from dizziness uneventfully.
Yes, so I had a colleague, a doctor, who had vestibular neuritis, which is an inflammation of the vestibular nerve, and it causes the sensation like the world is spinning. So my colleague reported even falling over when he was getting out of bed. He knew what it was right away, which helped eliminate any anxiety. And when he went to the mirror and saw his eyes beating, that nystagmus that we referred to, he also, it further told him that it was vestibular neuritis. And I remember seeing him at work staggering all over the place, and he would just say, "This is cool. This is what vestibular neuritis feels like. It feels like being drunk without a hangover." And he just went on about his day, going to work, gardening. Anyways, it all resolved without therapy, or perhaps it's better said that what he was doing day to day was therapy that helped his body readapt. Vestibular neuritis for the majority of patients leaves a permanent legacy in the way it controls the eye's movement. But when he had his vestibular system tested several years later during a training course, they confirmed that he didn't have any abnormalities that remained from the vestibular neuritis.
Hopefully, the knowledge imparted in this podcast will help people acquire knowledge to reduce anxiety they feel. Going back to the young lady for a second, a great deal of mindfulness is required to maintain composure and identify the internal sensations we wanted her to feel and become aware of, and then manipulate them to her advantage. I mean, it's challenging to size up what your visual system is bringing to the table when it comes to your balance, and then reduce that and increase what your other systems bring to the table.
Yes, that's an important point. Concussion patients often show disruption of automatic postural responses and difficulty in anticipating how they would or how they should adjust their posture. So this needs to be worked on too. Then we often see patients that can do a balance drill fine, but once you get them to combine it with a cognitive task, like naming flowers or countries that begin with the letter C, or do a visual scanning task, then they struggle. Take two. Or do a visual scanning task, then they struggle. So this needs to be trained. In a previous episode, I believe with Dr. Ma, regarding the neck, we discussed that studies have shown that even in NCAA athletes who sustained concussions and were rehabilitated and reintegrated into their sports, those athletes had a 50% increased risk of sustaining lower extremity injuries compared to their colleagues who did not sustain concussions. So being able to foster awareness to things that would normally fly under the radar is key.
Interesting. So either these patients had underlying undetected deficits pre-injury that made them more likely to sustain a concussion, or maybe these patients went back to sport a bit too early. Can you talk a bit about to what point you rehabilitate someone?
We rehabilitate them until they can do most balance activities that they want to do without symptoms, and to an extent that it will mitigate future risk of injury when they go back to the activities they plan on doing.
That makes sense. Some patients' lifestyle demand more therapy than others.
Yes, so for example, a carpenter that wants to go back on ladders and play competitive soccer will have to train his balance more than someone who is not very active and who has a sedentary job.
And then sometimes people panic under certain circumstances when they feel overwhelmed in their environments, as we discussed last episode. So this needs to be addressed.
We employ many psychological, energy management, and self-regulation techniques, often with the use of biofeedback to help with this.
Now, a lot of patients we see have been off exercise for some time, and this can make their balance worse. Exercise in general helps with balance.
Right. This makes intuitive sense. The more you do tasks that challenge your balance, the more you'll adapt. So exercise helps improve balance.
Exercise has many other positive benefits on post-concussion patients. Can you discuss the role of autonomic dysfunction? For our listeners, we introduced you to the autonomic nervous system in episode 5, The Glass is Half Full.
So much of the research on this comes out by a group headed by Dr. Letty in Buffalo. They explore the metabolic and physiologic changes that occur in post-concussion syndrome. They describe a change in the way the body regulates its cardiovascular and nervous system in post-concussion syndrome. This regulation is comprised of many things that we do every minute, like was discussed in episode 5. So things like focusing our eyes, digestion, salivating, sweating, regulating oxygenation of the blood and blood pressure, and so on. Things that almost all of us take for granted. Autonomic dysfunction has been linked with vestibular conditions and visual vestibular mismatch too. Even in those without concussion. So even improving performance in this system is relevant to these non-concussion patients.
So many wonder if these regulatory processes go back to normal with time.
For many, they don't, and these tend to be the patients we see. In fact, if we go a step above the autonomic nervous system, so the autonomic nervous system is classified as a branch of the peripheral nervous system. So a step above would be the central nervous system, which is the brain. So when the brain is dysregulated, The brain can kind of hijack the autonomic nervous system and put it in a fight or flight state, the same fight or flight state we discussed in episode 5.
So that will lead to fatigue, negative mood, decreased cognitive capacity, and so on.
Right, it's all related, which is why many relaxation strategies, energy management, and sleep management strategies can help. Training the autonomic nervous system with heart rate variability training using biofeedback to check this fight or flight response has also been helpful for patients to better influence what their autonomic nervous system is doing, in addition to cardiovascular exercise.
Yes, exercise is a big component to our program, even in those who were not active before.
Right. Regular aerobic exercise training has been shown to increase the parasympathetic branch of the autonomic nervous system, that rest and digest branch,
as opposed to the fight or flight branch, that sympathetic branch.
Right. Exactly. It also increases cerebral blood flow, which will support more efficient metabolism. Exercise has been shown in even the non-concussion population to have positive effects on mood, sleep, cognition, energy, headache, some aspects of dizziness, as we've discussed, and even our hormonal profiles. One hormone that has been associated with exercise is BDNF, or brain-derived neurotrophic factor.
Can you describe what BDNF does?
BDNF has been shown to have many beneficial effects on the nervous system. It helps support the integrity of existing neurons, and it encourages the development of new neurons and synapses. It is active in many parts of the brain and has a positive effect on cognition.
Okay, so it looks like there are many advantages to getting back into exercise sooner than later for post-concussion patients. So how does one get started generally?
So I feel this is best done on a case-by-case basis and handled by the healthcare team. The patients who need to have more conservative exercise regimens are those chronic migraine patients who are sensitive to almost all stimulation and all physical, emotional, and cognitive stress. For many patients who are not very physically active before the injury, starting with a daily walk to create the habit for exercise and get used to motion is a good start. Care should be taken not to push themselves too hard, as this can fatigue them and see them feel worse. These people need to get educated about how important exercise is in this context, and that they should actually be looking at it as medicine.
That reminds me of one patient who confessed that she hates exercise and never does it. But if it's medicine for her, then she will do it. And she did it.
Yeah, that was awesome.
It's an excellent medicine that is fairly inexpensive and has a low incidence of side effects and no incidence of drug interaction. The only thing is that it takes some effort.
I think supporting them by having them log their exercise and reviewing it with them with an eye to strategically advance it makes them feel part of a team and helps give them the recognition of improvements when they've made them. Most people I notice, once they feel success, they don't really need much more motivation. They just seem to enjoy it, and then they adhere to the program.
And for those that were athletically active before?
So for these patients, they have to be educated to limit their exertion as measured by their heart rates or their RPE, which stands for ratings of perceived exertion. We use the Buffalo Treadmill Protocol as an assessment tool to gauge how the patient's autonomic nervous system fares in the face of physical exertion. How is it able to automatically regulate the heart rate? How does the patient feel as the exercise demand is gradually increased? And so on. We can glean a lot of information from observing their performance and then giving the patient an exercise prescription that involves a target heart rate. Other factors in the patient's history factor in also. So for example, if the patient has neck issues, we may not recommend cycling, as it may put more strain on their necks until they learn how to control their neck muscles better. If they have a lot of balance and dizziness issues, we may recommend they don't do their training in the water if possible, as they have to learn how to recalibrate their senses on land first. If they have knee issues, then we may start with cycling. There are many considerations that go into that initial cardiovascular exercise prescription.
And here we are just talking about cardiovascular exercise prescription as a starting point. We will try to discuss in a future episode how the exercise prescription is strategically advanced to include more movement, visual and cognitive tasks to help facilitate recovery. Can you talk about how long it takes patients to start realizing benefits from a cardiovascular exercise regimen?
So usually patients start noticing improvement in their mood, and their ability to relax. And also they notice that the exercise seems easier and that if it flares up any symptoms like headaches or dizziness or nausea, it tends to resolve more quickly. When this happens varies from patient to patient, but in our experience, it happens anywhere from 2 to 4 weeks.
And then the exercise regimen is advanced.
Yes, this again is done on a case-by-case basis, but we're always trying to make recovery as efficient as possible without setting them back. Many patients are surprised when they get initial workout prescriptions of heart rates of only 100 or 110 beats per minute, but are pleased to see the progress after just a few weeks.
What about those patients who have a tough time maintaining their heart rates in that range?
The chest strap devices are the most accurate. Other devices can have some movement artifact and give a falsely high reading. When the heart rate seems to be jumping all over the place during a workout, we teach the patient how to measure their own heart rate using the old-fashioned way.
So just feeling your pulse and counting how many beats there are in 15 seconds and then multiplying that number by 4.
Yes, exactly. And often they'll see that the device may be responsible for the swings in the heart rate. The old-fashioned way works fine, and we get them to measure their heart rate when they feel like they've plateaued in terms of effort. We usually prescribe a 30-minute workout session, 5 minutes warm-up, 20 minutes of sustained exercise at the prescribed heart rate or RPE, and then 5 minutes of cool down. So they're measuring their heart rate sometime in that 20-minute window.
What about those patients who find it challenging to hold back? I mean, I know some of the athletes are anxious to get going, and so it can go against their mindset to hold back so much on effort.
This involves some educating the patient, that less is sometimes more. We had a very fit cyclist once that came to us, and he wasn't convinced that the approach of gradually increasing the cardiac load to respect that fatiguing point of the autonomic nervous system was the way to go. So what he found is that despite doing the same mileage on the bike, he was more irritable, he was making more cognitive mistakes at work, he was actually even gaining weight. He'd gained 10 pounds since the concussion, despite not changing his exercise regimen. Upon reducing his exercise load, all these things improved, including that weight that he'd gained.
Interesting. The fight or flight response has been shown to cause weight gain because of the stress hormones it releases.
Yeah, and perhaps he was not able to recruit muscles as efficiently because of the autonomic dysfunction, so he was not recruiting as much of his musculoskeletal system. For this patient, some cognitive behavioral therapy techniques was effective in getting him to change his behaviors, which in turn improved his mood and his outcomes.
Before we wrap up this program, I want to discuss the last of those most common diagnoses we see post-concussion causing dizziness, and that is vestibular migraine. I know we spent a lot of time in episodes 9 and 10 discussing migraines. I will try not to repeat any of that information, but many are not aware that migraine can cause dizziness. Can you explain to us how is it that migraine can cause dizziness?
Simply put, as we discussed in the last episode, migraine involves all parts of the brain. Much of those parts are also involved in balance and perception of stability. And so when migraine strikes, the functions of those regions involved in balance are compromised. So we discussed already in the last episode how far-reaching the vestibular system is. It involves areas in the inner ear, in the brainstem, in the subcortex, in the cortex, and it sends nerves to many muscles.
So why do some with migraines get dizziness and some don't?
It's hard to say. Many have a family history of migraines, and it's well known that there is a genetic susceptibility in most migraine sufferers. Also, the nature of concussion and metabolic changes that it creates and the neural circuits that are involved may make it more likely. Many don't know this, but 20% of all dizziness is said to be due to migraines, even in the non-concussion population, which makes it one of the top reasons for dizziness.
So how is it diagnosed?
First and foremost is keeping in mind that this is a common cause of dizziness. So one has to have a high index of clinical suspicion. If it's not on your radar, you're not going to catch it. For example, we had a patient that had no headache at all, but just dizziness, in addition to some other common concussion symptoms, like fatigue, feeling cognitively foggy, low stress tolerance, light and sound sensitivity, sleep disturbances, so on.
But no headaches.
Right. So we started treating her with many of our therapies that are just generally good for you, good for anyone. Things like regular strategic exercise program, energy management, cognitive behavioral therapy for insomnia, heart rate variability training, and so on. The thing that really made me clue in that she was having vestibular migraines was that when she was doing her vestibular therapy, at times she really struggled, and at times she did it showing no signs of deficit at all, which is unusual for a patient who may have dizziness from another cause other than migraine. So coincidentally, we'd already started treating her for migraines, although migraine wasn't really on our radar at that point.
Yes, like you said, a lot of the behavioral therapy are things that are just generally good for you.
Right, and so her dizziness converted from daily chronic dizziness to episodic dizziness. And in fact, after a few months, she did start developing a few migraine headaches, and so the dizziness and migraine headaches came on within a window of time spanning a few months.
That's how high of a clinical suspicion one has to have. Many people wouldn't have connected the two as belonging to the same entity.
Yes, and the dizziness seemed to be accentuated with classic migraine triggers like low pressure systems, stress, fatigue, that kind of thing. We just didn't realize it when she was always dizzy with no headaches. We could only connect it when she wasn't having the dizziness all the time anymore. And, she went from black to white, no dizziness at all and perfect balance, to dizzy and having pretty severe imbalance. Of course, we checked her for other causes of dizziness and we couldn't find anything.
It's interesting to note, but a study showed that 22% of migraine sufferers have BPPV. This models the picture.
Yes, it's interesting. I'm not sure why BPPV is more common in migraine as it is also in concussion. If we find BPPV, we treat it. And usually we can confirm that it's gone by ensuring that the jerk-like reflex that BPPV creates, called nystagmus, disappears. And then we take another history and do another bedside exam, investigating the patient's functional capabilities.
So you mentioned that many parts of the brain that are involved in dizziness and balance can be affected by migraine, and this can cause different patients with vestibular migraine to come in with many different symptoms. What are some of the symptoms these patients complain of?
Well, many complain of classic migraine symptoms as discussed in episode 9 and 10. But the dizziness can be very variable. It can be reported to be spinning, like in classic vertigo, but it can also be reported as rocking or lightheadedness or feeling strange in their environment, like everything's a bit off, like the proportion of their body parts or the room they're in don't feel like they are being accurately interpreted. Often these patients complain of light sensitivity to visually rich environments like markets or the fluttering of leaves, or the shimmering of lights between leaves, and so on. And many of them also report sensitivity to just movement in general.
And what many patients find interesting is that oftentimes symptoms that seem to not be related to migraine at all are related. Things like urinary discomfort, bowel issues, ear fullness, and so on.
Yes, because of this variety in the way patients describe their dizziness, it can be confused with many other potential diagnoses.
Hence, the attempt to try to rely on objective measures whenever we can, to treat all those things we can find that can contribute to dizziness, and maintaining a high index of suspicion for the diagnosis.
Right, that's a good summary. Sometimes it's easier to look at the problem in reverse. Rather than trying to identify the cause of dizziness, and usually there are several causes to the patient's dizziness, we look at how we can improve the dizziness imbalance.
Treatment for this class of migraine is like we discussed in our episodes on headaches.
Right. And for those that were found to have other causes of dizziness, like the causes we discussed in this episode and the last one, can have that treated to help their dizziness also.
That was an excellent and informative discussion about a topic that affects many post-concussion patients. Thank you, Dr. Chugh, for sharing your time and expertise.
My pleasure. Thank you.
Thank you for listening to the Concussion 101 podcast. If you enjoyed it, please subscribe to our podcast on iTunes and leave us a review. For more information about concussion-related topics, visit us at www.yorkconcussion.ca. Stay tuned for our next episode.